is there. I think user is free ready.
Yeah. What about it? It's on YouTube. What is live on? Why it is coming on YouTube?
No, they have also given a YouTube link, so
Link.
you don't even need a Zoom connection what is that? For just
Viewing.
watching.
Watching. Yeah.
For viewing, you can in Zoom. I think people can ask questions. It's a two-way.
Okay.
The audience can either type or they can ask
But
questions.
YouTube you can only watch.
YouTube, you can just watch.
Mm-hmm.
So they've given a link live on YouTube. It says view stream on YouTube or copy streaming link.
Okay.
Meaning more people without even logging into Zoom, you can watch. Last time also it was there. I was told.
Yeah. Good. That is good. That is convenient actually. If YouTube, anybody can log in from anywhere and watch it.
Boardroom.
I think the open. Navneet, you are taken off this sharing now from this thing.
Yes, sir.
You have stopped sharing, no?
Yes, sir. You can share it again if you wish to, sir.
Yeah. And after when I start the presentation, then only I will share now.
Yes, yes, definitely, sir. Definitely.
So where do I go for the share? Yeah. Okay. I got it.
Yes. This is directly can use this on the yes. And direct mic will be so it will be easy. Okay. Take it. I'm just seeing this presentation. Hello, Shibu. Hello.
Hello.
Can you hear me?
Morning, everybody.
Manas, I can hear you.
I can hear you.
Okay.
All good.
Yeah, I can see you. But your name is coming as Karan.
Yeah, no, that is mine. That is mine, Muzumdar.
Yeah, okay.
I'm using my son's laptop. That's why.
Yeah, but you have to, I think camera you have to adjust because only your upper part of face is seen. Yeah, that's fine now.
Yeah.
Morning, Sujanda.
Morning, everyone. Sir, Ahmedabad.
Yes, I'm from.
Yes, sir.
I'm from Modi's town.
Yes, I can see that. Megha, your slides okay?
This is
Going on, Sujanda.
It open?
Yes.
Still not.
Okay. Carry on.
Yeah, I need 10 minutes more.
Okay. Otherwise, we'll switch off. We'll switch over with some
So
other.
anyway, you are speaking first 10 minutes, no?
Yeah.
Mega open. నేను శ్రీధరాల इनको सुनाई देती फिर तो आवाज आती इनके पास आवाज नहीं आवाज आती
नहीं सुना चौक देता ऐसे एक्सप्रेशन होता नहीं बोला कुछ शांति से बैठे हैं
कैसे थे
कहाँ से आ रहा है ये सब
रहमा
कुछ नहीं दे रहा शांति से बैठे थे ये स्लाइड्स क्या हो रहा है इधर उधर ये डॉट्स क्या है कुछ नहीं अच्छा ये तेरा है ये ऑन मत करना तो दिख जाएगा ये कौन है ऐसे एक दूसरे चैनल में देखते रहेंगे पढ़ेगा कौन पहले
पता ही नहीं है हाँ तभी तो आवाज आएगी ना ये विसन क्या उसका बड़ा इसको सुन नहीं बात
दिख तो नहीं गया
वो जुड़ते जा रहे हैं ये कैसे ऑफिस से
देखना है
शिबू भी ले स्टार्ट है
सामने
Did that slide come properly?
Yes, we saw. Shivu.
Okay.
Yeah.
गाली खाने का मन ये सुचंदा भट्टा
হ্যালো, কখন আমি মারতে পারতাম আমি কনফারেন্স 2 o'clock। হ্যালো,
Hello. Hello. Can you hear me?
yeah, yes, very clear. Now we can't hear you.
ये नवनीत जी ये YouTube लिंक भी है। हेलो।
यस सर, आप अगर चैट देखेंगे, चैट में है सर, जो सेकंड वाला लिंक है वो लिंक है सर। मैं फिर से ऐड कर देता हूँ उस लिंक को। यू कैन कॉपी पेस्ट इट देयर।
Where in chat?
इट इन चैट सर, इन चैट मैडम।
Okay. Where is that from?
Yeah, no, that YouTube link. Suchanda, when you start now, you can announce that YouTube link so that people can access that.
Where is the link?
People who don't have.
It's in my WhatsApp. I'm checking this. Okay.
Host official.
What I flashed the YouTube is coming, huh?
Yes madam, it's there.
Okay, fine.
Suchanda,
Yes.
I'm ready. Can it just be checked once? Can I share?
Yeah, just share once.
Oh, the other participant is sharing, so until then I cannot share, it says.
Okay, anyway, it's coming now. I'll stop share. Now you do. You do now.
Okay.
Yeah, it's coming.
It's seen?
Yeah, it's in.
All right. Okay then.
You go, then I'll share. Yeah.
Done?
Yeah. Done.
Able to see yours, right?
Yeah, I will do it. It's okay. We have still 5 minutes left now.
Okay. Okay.
All are there, no?
Yeah.
The internet connection is unstable.
I'll just call Ari.
ID is not there. No?
I'm calling him.
It's already 12, no? It's not 12.
No. I don't know. By my watch, it's not 12 yet.
मेरा घड़ी में 12:02 हो गया.
मेरा 12:02.
Correct.
Mine anyway.
It's in different country. I'm in Hyderabad. She's in Secunderabad. She's in Secunderabad, I think.
Okay. Let's start after. Okay, fine. Okay. So let's start. Let's start. Good afternoon, everybody. So we'll start today's webinar from the Neurological Society of India. And this will be on posterior fossa tumors in children. And before I start, actually, I would like to pay my homage to we are really devastated here at Nizam's Institute because we lost one of our professors of neurology, Professor Meena, who was a reputed person of neuromuscular diseases, and she had a massive MI, and we lost her unfortunately yesterday, and we all are devastated. But anyway, we have to go on with the webinar. So life goes on. And she was young to leave us untimely, and so paying a homage to her, we start the webinar here. So today we have for posterior fossa tumor in children, we have 5 distinguished speakers from the country. We have Dr. Megha will be talking about pathology, and she's from Nizam's Institute. We have Professor Manas Panigrai who will talk about brainstem tumors. We have Dr. Shibu Pillai who will be from Bangalore, who will be speaking on ependymomas. We have Professor Dattatreya Majumdar from KEM Mumbai who will be speaking on medulloblastomas, and we have Dr. Ari Bezagan from NIMHANS will be speaking on the decision making and what to do when you have a posterior fossa tumor. So with these 5 speakers, I start now. I'll just touch little bit bits and pieces, different areas which cannot be covered in the whole symposium because it's a huge topic, and we obviously cannot cover all. But I'll just go a little bit in a zest of touching here and there. So if you look at the history, it only started in the 20th century, and but then the first report was reported way back in 600 AD, and this was a personal collections of James Goodrich from New York, and where he found a skull from Peru which had a trephine in the suboccipital bone with a healed margin, which indicates that the person actually survived the procedure. And the next report was from Turkey, and their anatomic procedures were described as way back in 130 to 200 AD, and then some of the earliest anatomical drawings on posterior fossa anatomy was found actually from the Leonardo da Vinci's anatomical studies. And then subsequently it evolved. There are many things on history, but then that's beyond the scope. So what we have tumors like this, which all of us neurosurgeons encounter on a daily basis. This is all these are of 4 different 7-year-old girl. And you see this images look almost similar, except for the last one. And then this is a medulloblastoma. This came out as an ependymoma. This came out as a brainstem pilocytic astrocytoma. And of course, this is characteristically the diffuse interfrontine. So, and all have a different way of prognosis. And in the small posterior fossa, where different types of tumors come in kids. This is another case of a GBM, and which is of course a rare entity. So we will be talking about the most important ones. We cannot cover all of them. So then the question comes, why we need to discuss. If you look at the literature, there's no proper statistics in India. There are very few literature support from India, and we all rely on the Western data. The literature lacks prospective series that track the evolution, neurological deficit over time. So that's the reason why we need to discuss here and see like how we go forward with in managing these diseases. We all should know that kids are different from adults. If you divide the kids into 3 categories, like less than 2 years, 3 to 12 years, where you get the bulk of the tumor, and 12 to 18 years, types and prognosis varies tremendously. 12 to 18 years is more or less behaves like adults. Less than 2 years is the most difficult age group to cover. So just looking at a glimpse of statistics, if you see it, it is like 60 to 70% of all brain tumors in children. And the most common ones are the medulloblastoma, 40%, astrocytoma, 20 to 35%, and ependymoma, 10%. We'll be discussed extensively about medullo and ependymoma. Astrocytoma will be covered in a different webinar along with other astrocytomas. So we have left that out because it demands huge time. If you look at less than 2 years incidence, it is around 32.4%, and less than 2 months incidence is also pretty bad, of 17.9% actually. And if you look at the current latest 5-year survival rates, astrocytomas survive for 90%, medulloblastomas and ependymoma 60%, medulloblastoma 60 to 80%. So, as they grow up, there are a lot of challenging problems they face, and we need to, as physicians and surgeons, we need to deal with them, and we need to discuss why. So I'll just touch on the rare tumors. I'll just name the rare tumors which are there in posterior fossa for the sake of record, but we will not be discussing today all these things. Chordoma, choroid plexus papilloma, vestibular schwannoma, ganglioma, dermoid, epidermoid, lermid ductlose, meningioma, meningoblastoma. All this can occur in the kids, but they are very rare, so there are not much reports in the literature on them. And the uncommon pediatric posterior fossa tumors, again, which are very recently reported, are all this like ATRTs with this classification. These are for the pathological distinction. We call them ETMR, CRENET, RGNT. These are the latest which are coming up with more and more evolution of the pathological diagnosis. And maybe Dr. Megha will touch on them, or maybe not, but then we need to know the names which are coming up, and it will be very, as days goes, I'm sure this will gain more and more importance. So the syndromes in posterior fossa tumor we need to know are all this. So rhabdoid predisposition syndrome, like the ATRTs, Life-Romany, Charcot-Gorlin, where medulloblastoma is there, Aicardi also, along with medulloblastoma, Rubinstein-Tabby, and neurofibromatosis. So this is a special category, less than 2 years of age. And so I just touched upon it, that their clinical presentation is subtle, like they have large head, irritability, poor feeding, failure to thrive, and tumor can reach great size before being diagnosed. The circulating blood volume of the young baby is smaller, and the head is relatively large. So we need to remember this in mind. Thermoregulation is poor. Maturity of the brain, of the skull, and of the soft tissue of the head is incomplete. So they are a different and the difficult group. Again, what we need to consider when we operate on these kits, on the very small ones, the preparatory solutions needs to be warmed, warm intravenous fluids. We need to keep warm air currents or air blankets. Replace with plasma platelet 1:1. Circulating volume of blood is lost, approximately 80 ml per kg is lost. You need to do that. You should take care of flexion of the neck, because compression on the ET tube leads to high airway pressure, increased venous bleeding in the field. Mortality between 7.3 to 33%. Is there in this case in posterior fossa tumor. Conformal radiotherapy, we should know that it's not chemotherapy. Even conformal radiotherapy can now be applied to posterior fossa in infants with dose modification. This is there. And Of course, we cannot do a sitting position. Most of the infants in prone position, bleeding is important even because there are still persistence of fetal dural venous patterns in infants, and tumors with high grade histology are usually there in less than 2 years and are highly vascularized. And I stop here. Hydrocephalus in posterior fossa tumors is again presentation is around 70 to 90%. 7 to 17% present with metastasis right at the beginning, and 10 to 40% tend to demonstrate persistent hydrocephalus even after resection of the tumor. So if you look at the current series which are available in the literature, less than 3 years of age, you see the number is pretty high who has gone into persistent hydrocephalus, 68% in one, 31%, 37% compared to more than. So we need to deal with them, and there are various ways to deal with them. So what are the factors if you look at the presence of persistent hydrocephalus, young age, severity of hydrocephalus and presentation, tumor location, tumor pathology, and extent of resection. These are the factors if they are there. So we need to look at this, which has come out at CPPRH scoring. And if the scoring is very high, then you know that the child is going into persistent hydrocephalus and you have to act accordingly. Okay. So pre-resection for hydrocephalus, there is a debate over when to do a shunt or an ETV, and the advantage if you do a shunt or some sort of diversion, easy resection of tumors, smooth post-op mortality. But the disadvantage of that it has been reported by Dr. Goel from India, that it moves your tumor close to the brainstem, so dissection is hazardous. Of course, infection obstruction remains, clinical deterioration occurs, there may be hemorrhage, or there may be tentorial ionization or theoretical risk of metastatic cells to the catheter, though this has been reported very rarely, and there may be some over-treatment. So hydrocephalus and ETB, if you look at it, preferred for immediate relief of obstruction, post-resection, most of the people are doing these days. However, if you look at the paper from 2007, you find that ETB fails in around 55% compared to a shunt which fails in only 25%. So with this, I rest my case. I hand over to Dr. Megha, who will take us through the pathology, and after that, we will have the subsequent speakers. So over to Dr. Megha now.
Okay, can I start, Suchinda? Hello?
Yes, please.
Hello?
Yes, please.
Yes, thank you, Suchinda. So I shall be dealing with the pathology of the common posterior fossa tumors which are seen in children. Where's this screen?
You just need to tap me.
Yes, so that's basically, yes. So that's just basically naming the different posterior fossa tumors according to the different structures in the posterior fossa and the importance of these which we are going to discuss today. Now, if I have to put these tumors or arrange these tumors in according to their histopathologic terminologies, then in posterior fossa, we can see the low-grade gliomas, which are the grade 1 and grade 2. We can see high-grade diffuse gliomas, which belong to the WHO grade 3 and 4 category. We have various types of ependymoma, and of course, we have embryonal tumors, which include the medulloblastoma, the ATRT, and the ETMR. And I shall be dealing with each of these entities according to their updates and the molecular pathology as per the WHO classification 2016. So pilocytic astrocytoma by far I think is the commonest glioma which is seen in the posterior fossa, which is WHO grade 1. And the pathology of pilocytic astrocytoma is entirely dictated by presence of these elongated pyloid processes, which can be easily seen on a squash smear as well as an histopathologic section. And of course, the famous eosinophilic granular bodies, which are these round globular structures and the elongated Rosenthal fibers. And we have a biphasic pattern. There will be a lot of microcysts within a pilocytic astrocytoma, which is surrounded by the glial cells. Now, the reporting pathologist has to remember that every time classic features may not be seen, a lot of atypical features have also been reported with pilocytic. Particularly, they can look very hypercellular and aggressive. They can have glomerular type of microvascular proliferation. They can even be necrotic, which actually are the markers of WHO grade 4 lesion. And the posterior fossa pilocytic astrocytomas can often majorly look like oligodendrogliomas. So we have to remember about these variations in pilocytic, and even in presence of microvascular proliferation and necrosis, they remain WHO grade 1 and do not behave aggressively. The most important differential diagnosis, of course, would be a pyloid gliosis, which can occur in the periphery of a hemangioblastoma and should not be mistaken for a pilocytic astrocytoma. Now, it's more or less an HND stain diagnosis. Sometimes we can take the help of immunohistochemical markers, and being a glioma, it will be very brightly positive for GFAP, Y-metin, and S100. However, I think the most important marker which can come to the rescue of a pathologist in cases of a problem of a diffuse glioma is a neurofilament immunohistochemistry, which highlights the axons. So if you are going to see these axons running in between the tumor cells, you're most likely dealing with a diffuse glioma, and in absence of these axons shows a circumscribed pattern of a tumor which is consistent with that of a pilocytic astrocytoma. These tumors, everybody knows, are driven by the MAP kinase pathway and can show a lot of BRAF alterations. The commonest of that is a BRAF fusion, and we can have non-fusion mutations, of which the commonest is V600E type of mutation. Now, the mutation and the fusion proteins are not uniformly distributed in all types of pilocytic, and the fusion BRAF is most predominant in the infratentorial pilocytics, whereas the other V600E will be in the supratentorial pilocytics. Another common thing about low-grade gliomas is their propensity to undergo spontaneous regression, which has been explained by the P60 retinoblastoma pathway. And this has been put forth as a very important immunohistochemical markers, which has been studied in a publication that if you get loss of P16 expression by doing immunohistochemistry, then that has been shown as a marker of a poor prognosis in a pilocytic astrocytoma, and this immunohistochemical marker is widely available and can be easily done. So just to summarize the various types of mutations, the methods which can be used, and the utility is when you talk about posterior fossa pilocytic astrocytomas, the commonest and the most predominant is the BRAF fusion protein, which can be done by FISH, and this is of very important diagnostic use because this is not replicated in any other pediatric tumor or a diffuse glioma, and it is exclusive to the diagnosis of pilocytic astrocytoma. The V600E mutation can be very easily demonstrated by doing a monoclonal immunohistochemical staining with a known antibody available in the market. Now, there have been differences in the opinion about the prognostic utility of this fusion protein, and as of now the use of it has been restricted to diagnostic measures of pilocytic astrocytoma. Now, anaplasia has not been officially been recognized by WHO. It has not been given a definite grade, but anaplasia has been definitely reported in pilocytic astrocytomas, wherein they can look very bizarre. They can acquire a lot of atypical mitosis, the vascular proliferation and palisading necrosis, and the Ki67 will be very high in these tumors. So this kind of anaplasia has been reported in a primary presentation or in tumors which have been treated with radiotherapy. And this is important to be remembered, though it is a rare phenomenon in pilocytic. Most of them would tend to behave like a grade 1 tumor. There are various other mutations which have been found and in pilocytic, and I think the most recent one is an histone mutation H3K27M, which is actually a marker of diffuse glioma. So some tumors have been studied which are circumscribed gliomas, and in a study 7 of these tumors were shown to have morphology of pilocytic, and on follow-up of these patients it was shown that presence of histone mutations brings a poorer outcome to a pilocytic as against the circumscribed gliomas which do not have these mutations, but the prognosis remains better than the H3K27M diffuse gliomas. Now, it is important to remember that even if pilocytic shows an H3K27M mutation, it still remains a WHO grade 1 tumor and it should not be upgraded to a WHO grade 4. So the common entity which shows these mutations and which has been defined as a grade 4 tumor by WHO is what is described as a diffuse midline glioma, wherein we get a lysine to methionine substitution at the 27th position of a H3 histone protein, and these histones are known to play a key role in state of chromatin, and presence of these mutations can interfere with chromatin function, which establishes tumorigenesis in these tumors. So in this diagram, you can see that in children below 10 years, high-grade gliomas almost always express histone mutations, and as you grow older in young patients, you have IDH1 mutations, which will be absolutely absent in pediatric high-grade gliomas. Less than 4% of fused gliomas of the posterior fossa can show IDH mutations, which have been adolescent population and not in children less than 10 years. We have other mutations like ATRX, ACVR1, PDGFRA, and TP53, which are in combination defined as a WHO grade 4 histopathology. Now, histopathologically, diffuse midline glioma is a very heterogeneous disease. It's a great mimicker of any other tumor in the posterior fossa. The commonest morphology, however, is like that of a WHO grade 3-4 astrocytoma. Nevertheless, it is important to remember that even if DIPG looks like a low-grade glioma, its behavior does not change. So, histology is not a predictor of behavior in DIPG, and every H3K27M tumor, irrespective of its pathology, will be labeled as a WHO grade 4 tumor. Now, how to analyze this mutation is the most rapid, well-standardized and reproducible tool in pathology, which is very pathologist friendly, is an immunohistochemical antibody, which is a monoclonal antibody against these mutations widely available for clinical use. And you can run this immunohistochemistry, which shows bright nuclear expression of this marker, which says that the tumor is H3K27M positive. And the importance of immunohistochemistry is more because most of the times the tissue which is taken out from the brainstem is limited. It may not be able to be submitted for high throughput studies, and detection of this single cell positivity makes IHC superior to the techniques for diagnosis of this tumor, and this immunohistochemistry is effective of the morphology. In addition to the H3K27M mutant tumors, MYC amplification has also been shown, and there are 3 molecular subtypes which are being proposed for the pediatric high-grade gliomas of the posterior fossa. The next in line would be an ependymoma, which arises from the ependymal lining. The conventional ependymomas which are seen in posterior fossa is either the grade 2 classic one, and more than that, what is more common in children is the grade 3 anaplastic ependymoma. Now, every ependymoma by histopathology is going to show rosettes. So you can have a true rosettes wherein you have an ependymal canal in the center, or a perivascular pseudo rosette where the cells are arranged in the periphery of a vessel. If you see more atypical mitosis and necrosis, you would upgrade the tumor to a WHO grade 3. And immunohistochemical marker of rescue EMA, which shows this beautiful perineal tumor. Now, posterior fossa molecular pathology of the ependymomas is still upcoming, and recently there have been 2 groups which have been put forth, which is group A, wherein the tumor arises from the 4th ventricle and undergoes an extracranial dissemination either along the brainstem or the external surface of the cerebellum, whereas the group B tumors, which begin in the fourth ventricle, run along the brainstem, or they are present as intramedullary lesions in spinal canal. There are different chromosomal changes wherein the group A tumors are characterized by deletion of chromosome 22q, addition of chromosome 1. They are more seen in pediatric age group as against the group B, which have a number of chromosomal aberrations. And follow-up of these two groups of tumors, it has been shown that group A tumors tend to be better than the group B tumors. Coming to medulloblastomas, the commonest embryonal tumor and uniformly WHO grade 4 tumor seen in posterior fossa in children. Morphologic subtypes are divided into classic, wherein the tumor looks like a small blue round cell tumor, can have a lot of Homer type of pseudorosettes. If the medulloblastoma shows nodularity, nodules are very poor. Internodular regions are anaplastic and hypercellular. Large cell, the large anaplastic, common terminology of large cell anaplastic medulloblastoma, wherein you get increase in the cell size, lot of anaplasia, cell to cell wrapping, hypochromia, mitosis, and necrosis. A very well-known but rather a rare variant of medulloblastoma would be medulloblastoma with extensive nodularity, which looks like a bunch of grapes on radiology and shows those multiple small nodules on histopathology highlighted on the reticulin special stain, which is supposed to be the best prognostic form of medulloblastoma. Some unknown differentiations can also be seen in medulloblastoma, like a myogenic or a melanotic differentiation. Immunohistochemically, as against the gliomas, medullos are known to express neuronal markers, which can either be a primitive neuronal and advanced now, important than histopathology, as important as histopathology is to know the molecular genetics, because very well-known figure, all of us have identified these subgroups of medulloblastoma into Wind, SHH, the group 3 and group 4 medulloblastomas. The prevalence varies, and the highest prevalence, unfortunately, is that of group 4. There is a definite genotype-phenotype correlation, of course, wherein most of the SHH medulloblastomas will be desmoplastic nodular. The group 3 and group 4 medulloblastomas mostly look like large cell anaplastic or classic, whereas the Wind medulloblastomas are classic, and we all know the most favorable subtype would be a Wind medulloblastoma. I also want to bring your attention to the changes that each of these medulloblastomas show a lot of chromosomal abnormalities which are subtype specific. They can have genetic and epigenetic changes in each of these subtypes, and medulloblastomas can show even an inter-subtype heterogeneity, and actually 12 subtypes of medulloblastoma have been put forth, which differ according to the age and the outcome of the patient. And this has been done predominantly in the form of methylation studies. So just to summarize, this is a table in a well-published article which shows the different techniques which can be used for molecular subgrouping of medulloblastoma, which is very important. Now, which technique to be used has not been particularly mentioned by WHO, and it will depend on the availability of that particular lab and the wisdom of the pathologist to use that techniques. But what has been practically widely available is immunohistochemical differentiation in moleculars with the help of immunohistochemistry, including beta-catenin, GAP1 and YAP1, where nuclear beta-catenin is a marker of Wind. Positivity for YAP1 and GAP1 says that it's an SHH tumor, and if you get all the three negative, it belongs to non-Wind, non-SHH. Now, unfortunately, immunohistochemistry does not differentiate into group 3 or 4, but it still remains of practical utility because it can essentially subgroup the medulloblastoma into 3 subgroups which are clinically useful. So the diagnosis of medulloblastoma, the integrated diagnosis is going to look like this. The first is the description of the tumor along with the WHO grade, the subgrouping of the tumor, and if you have additional genetic alteration is going to be an integrated diagnosis given in a pathology report. Now, having said that, it is also important to know that the molecular subgrouping and the histologic subgrouping parallels the prognostic behavior. So as much as you give importance to the molecular subgrouping of medulloblastoma, it is also important to know the histologic subtype because there is a good genotype-phenotype correlation. The next embryonal tumor in line, which is more aggressive, is what is described as atypical teratoid rhabdoid tumor, which is rare 1% of the pediatric tumor. And this is characterized by presence of INI1 mutations because of loss of long arm of chromosome 22, resulting in loss of the INI1 protein.
I think we have lost connection with Dr. Megha. We have lost connection with Dr. Megha, I believe.
Yeah, she's connecting again, madam.
Yeah, I think, and we are. Megha, are you there?
Hello, Suchanda?
Yeah, we are not able to hear any audio from you right now. How
Can you hear me now?
Your audio is not coming.
Yes. Yes, then will be the ETMR, the embryonal tumor with multi-layer rosettes, which is a combination of ET and TR, ependymоblastoma, and medulloepithelioma. And all these morphologies have been shown to have a common C19MC alteration. As the name goes by, these show a lot of rosettes. When there is necrotic or fibrillary material in center, they can have papillary or tubular architecture, and again these are very highly mitotically active tumors. The immunohistochemical surrogate for the C19MC alteration is an antibody by name LIC28A, and it is important to do this immunohistochemical marker in every round cell tumor of the posterior fossa. Now, having said all these about the histopathology and the molecular pathology of these tumors, what is important to know that the molecular techniques are not similar for the diagnosis of every tumor. So what remains is our hand to use the tissue to its maximum utility to preserve the tissue with optimal fixation and maybe preserve it further if in case a gene expression profiling or methylation profiling is necessary. So the tissue needs to be immediately fixed in a 10% neutral buffered formalin for 6 to 72 hours, which is important for routine HND sections and special stains. Immunohistochemistry, everybody has to know that there are important immunohistochemical surrogates for most of the molecular cytogenetics in these tumors, and these antibodies are very readily available and can be very well done to know the molecular subgroup of each of these tumors. And immunohistochemical chemistry as a technique requires an adequate fixation for 12 to 24 hours. A lot of molecular studies
left because
can be done even on fixed tissues. But if you need a fresh tissue, then the tissue can be preserved and snap frozen at -80 degrees. So I think with that, I end my contribution on pathologic part of posterior fossa tumors. Thank you.
Thank you, Megha. It was quite informative for all of us, but I cannot allow questions at this point of time because the time has been overshot. So we'll go to the next speaker. And the next speaker is Dr. Muzumdar from KEM Mumbai, and he will be speaking on medulloblastomas. Dr. Muzumdar, please. You.
Can you hear us?
Yes, yes, we can hear it.
Okay. Can you see my presentation?
Not yet. You have to share it.
Yeah, I've already shared it.
It's seeing only your picture.
Can you share? Can you see it?
Yes,
No, I can see you.
Oh, it has screen sharing has failed to start. It said.
So should we go to the next speaker and then come back to you?
Yeah, actually I'm doing it. So can you see it now?
No. You have.
Yeah, it will come now. It will come now. I think started it.
Yeah.
It has come.
Yeah.
Yes, yes.
Okay. So I'm thank you, Suchanda. And now I will take it forward very quickly on the contemporary management of medulloblastoma, because I think apart from the most of the important posterior fossa tumors, if you consider medulloblastoma has been singled out because it is molecularly heterogeneous and it has a distinct phenotype. And the most important thing is that it has diverse biological behavior and contrasting clinical outcome. Most important thing is that there is encouraging response to adjuvant therapy. That's why medulloblastoma is the most commonly seen tumor, and we have to absolutely give it an appropriate therapy so that the outcome is good. Now, why? I'm going to talk more about a comprehensive role of management of medulloblastomas. And most of the Western data that we see, it is not mirrored in the developing countries because of our healthcare, socio-economic constraints, and uniformity of care that we have with widespread variations in clinical practice. So there is a need for having a multidisciplinary team approach involving everything, all aspects: neuroradiology, neurosurgery, neuropathology, radiation oncology, medical oncology, and rehabilitative services for optimizing clinical outcomes. So what we did at ISNO, and I'm going to speak because this topic has been discussed at length at many forums. And what Megha said just now about the diverse pathology and the different types of immunological methods to diagnose medulloblastomas and take it forward. At ISNO, we had an expert multidisciplinary panel which involved everybody, and we formed a national consensus guidelines. So first and foremost, for a surgeon, we need to have adequate radiology. So that the radiology forms an important part of the pre-surgical workup. And we need to, even though the radiologist reports the scan, we need to understand the scan for carrying the treatment in an appropriate manner. So what we need to tell the radiologist that we need to have at least the axial T1, T2, and flare images of the brain, and fat suppressed T1 imaging with reconstruction. So here you can make out whether the tumor is soft, it is hard. So all these images helps us to determine the nature and the consistency and the texture of the tumor as what we see at surgery. So newer techniques which involve radiology will include MR spectroscopy, or you can do 3D ASL imaging of the brain, and so on and so forth. If these are optional acquisitions, so the minimum thing should be an axial T1, T2, and flare. With obviously we have to have the imaging of the spine also, if possible. Most of these patients do not have spine; they may just come on a CT scan or a MRI brain. But if possible, we should get a preoperative spinal imaging to see whether there is leptomeningeal dissemination. So first and foremost, how would we diagnose medulloblastoma on radiology? Of all the tumors, medulloblastoma, histiocytoma, and ependymoma, medulloblastoma will be hyperdense on plain CT. So plain CT scan is most important to be seen first if it is available. If it is a hyperdense, you are most likely dealing with a medulloblastoma. On MR imaging, what a surgeon should see? But you should see whether it is hypointense on T2 or hyperintense, because hyperintense would be soft and suckable tumor at surgery. Hypointense would be hard, would be calcific, and sometimes you have to see the adherence and proximity to the brainstem, vascular, and obviously you have to differentiate from astrocytoma and ependymoma. As you know, there are distinguishing characters which I don't want to go in detail, but there are distinct characteristics which would distinguish an ependymoma, which would go into the lateral recess, into the spine, unlikely to be a medulloblastoma. So on CT scan and MRI, we should be sure, okay, that we are dealing with medulloblastoma. As you see on the right side, you have examples of a T1 and T2 images of a classical medulloblastoma. How would a surgeon know that what is he dealing with? Now I'm coming straight away to the molecular typing. We know that there are 4 types. The which is then group 4, group 3 being the worst. Now, how would you diagnose a wind medulloblastoma? So, wind medulloblastoma, if you would see, would be morely in the lateral recess. It would be hypointense a little bit on T2 vectored images, and it would show restricted diffusion. If you see that this is a tumor, the upper left corner would be a wind medulloblastoma. SHH would be more like a desmoplastic. It would be lateralized. It would be solid. It would be compact. There will be some amount of edema, and it also showed restriction on diffusion. Group 3 would be something like this. It would be a small or a tumor. And if you see that the wall of the fourth ventricle is mostly intact in these cases. In group 4, you would have a large tumor which would be intraventricular, and it would expand the posterior fossa or the fourth ventricle and cause hydrocephalus. So this is the molecular subtype which every surgeon should know what we are looking into, considering the demographics, the clinical features, the genetic and the epigenetic expression, that and get an idea that what we are dealing with, which is a classical wind or a desmoplastic SHS, or a group 3 or a group 4, which is non-wind and non-SHS medulloblastoma. At surgery, the goal of surgery would be a safe maximal resection of tumor with no added neurological deficit. There are many issues in the patient where you have to see the neurology of the patient, whether you have an operating theater facilities, you have waiting list, cost constraints, whether the patient needs CSF diversion, surgical positioning, extent of resection, sequelae and complications, as well as whether you are able to get a post-op MRI within 24 to 48 hours or at least at 2 to 3 weeks. The clinical characteristics of the medulloblastoma that we see mainly in our country is they are large-sized tumors, they are midline, they come often with blindness, they have secondary optic atrophy, and they have gross hydrocephalus. And all these factors bear an important perspective on the cognitive and intellectual impairment of the patient. Sometimes the patient comes with a huge tumor in the posterior and has an impending death during admission in the hospital. This is most likely a variant. This is most likely could be an ATRT. And here you have to discuss with the family. The family has to be counseled about the outcome. Some patients relatives may not opt for a treatment. If they don't opt for a treatment, you have to respect their decision. So, or otherwise, in this patient, as we know, the prognosis is very poor, and any aggressive form of treatment may not have a gratifying outcome. So what we do in preoperative planning, most of the patients are operated early, because this is a posterior midline fossa tumor, they are prone to complications. So they should be operated on as what I would do in a protocol on the day of admission or within 24 hours. Usually we do not do a CSF diversion procedure unless the patient is clinically sick or having gross hydrocephalus. You can prime the patient with intravenous steroids for 24 to 48 hours. If there is no, if the patient cannot be operated early enough, and you can do either a VP-shunt or an ETV as what facilities are there in the given setup. So this I had originally mentioned in my experience of 365 patients of medulloblastoma way back in 2011. Adherence to surgery would be you have to have high magnification, a good anesthesia, high magnification surgical microscopes, good neurosurgical instrumentation, skill, obviously, and excellent ICU and rehab. So management of hydrocephalus. The management of hydrocephalus is absolutely critical. The CSF, if you take out the CSF, there's always a risk of upward herniation, of the tumor can bleed, and obviously if you put a shunt, there is always a chance of shunt infection, shunt malfunction of 20%, shunt dependency, or rarely seedling or metastasis. So the management of hydrocephalus usually in this patient should be if the patient is extremely sick or the patient has got a post-operative persistent progressive symptomatic hydrocephalus. So sequelae, we are always worried about the surgery and the sequelae following surgery. So a prolonged cerebral retraction should be avoided because it can damage the dentate nuclei and the dentatorubro-thalamic cortical pathways. You could have a long-term speech and language apraxia to the tune of almost 50%. And these patients usually can land up with long-term neuropsychological dysfunction and may require active rehabilitation measures. Very rarely now, mortality has come down significantly with improved microsurgery and anesthesia. The mortality up to 1%, and patients sometimes can have sudden hypoxia, brainstem edema, clot, or can have aseptic or pyogenic meningitis. So I won't go too much detail into the pathology. You should have this minimum testing which is recommended by in the consensus. So you should have a reticulin stain, you should have IHC for proliferative activity, MIB labeling index, and if you have the immunohistochemistry, which is cyanoptophysin and NSI, that would be better. I wouldn't too much of the details about beta-catenin GAB and YAG, which Megha has already alluded to. And the molecular diagnosis should be absolutely perfect. It should mention the histological diagnosis, the grading of the tumor, the molecular subtypings, and the genetic alterations. And the risk stratification is now further divided into low risk, standard risk, high risk, and very high risk in the WIND, SHS, and group 3, group 4 tumors. So if in SHS you have the T53 as well as T53 wild type tumors. So there are about 12 groups of medulloblastoma, but for a surgeon, I think a good resection with minimal deficits post-operatively or no deficits should be done. As far as radiation is concerned, as soon as the tumor is excised, you should refer the patient to the radiation oncologist within 7 to 10 days, and preferably the radiation should start in 2 to 3 weeks after the surgery, and not definitely after 1.5 months, because there is a high chance that the tumor would come back. And the radiation techniques are standard. It's a craniospinal irradiation, and the whole radiation process takes about a month and a half to complete. Adjuvant chemotherapy also is important, and in children under 3 years of age, sometimes you can give concurrent chemotherapy with RT in children around 4 to 5 years old, or you can give high-dose chemotherapy with autologous stem cell rescue in patients who are relapsing. So salvage therapy is also advised in relapse or recurrent medulloblastoma. So the standard is the Packer's regimen, which is platinum-based, and the chemotherapy toxicity also should be taken into consideration. The ototoxicity, nephrotoxicity, they have hematological toxicity that needs to be looked into. And follow-up is most important. So you need to have a detailed physical examination. You need to have a contrast exam, MRI of the brain and the spine 6 to 12 weeks after completion of the therapy. You have to, if the tumor relapses after standard therapy, then you need to give salvage therapy. And we always have failures. So if there is a recurrent medulloblastoma, most of the time it recurs 25% of the time within 2 years. And at that time, you need to again do the MRI brain spine, you need to do the CSF cytology, bone marrow examination, and the management is case by case basis. So if the patient manifests with the local recurrence with a significant mass effect and hydrocephalus, then you might need to go in and decompress the tumor and send the patient again for a re-irradiation after 2 years, if the patient presents after 2 years, or sometimes you can do autologous bone marrow with a rescue with myeloablative therapy. So here is a patient who has a long-term effects of radiation, and sometimes you can have a glioblastoma in the supratentorial region for a patient who has been operated for medulloblastoma maybe 8 to 10 years after surgery. So this needs to be kept in mind. This patient presented with aphasia 8 years after surgery for medulloblastoma. So these things need to be kept in mind. So if I talk about medulloblastoma surgery, whatever if your anesthetists are good, then you can do the sitting position quite comfortably, even if there is a risk of air embolism. There are certain centers who still go ahead, advocate sitting position, but the safest position to do it will be the prone position, where you get a little chance of air embolism. And obviously, it's a little bit difficult to do, but with training, I think prone position would be the safest position for any posterior fossa tumor to be done. I think medulloblastoma has got a prognosis if treated correctly and within time. We need to adhere to this consensus which very well 2017, and that would to have, since always we are worried about Indian data, we need to have this uniformity of care, and thus that would improve our disease-related outcomes. And obviously, we can compare the results between the institutions within the country. So with that, I will end. Thank my new KEM Hospital and the Tata Memorial Hospital from where this experience comes. Thank you very much.
Thank you, Dr. Majumdar. And I have been asking for questions, but in the chat, but I don't think so. People are having, you have explained so well that I think people are not having questions, or they're not. So anyway, we'll go ahead with the next talk. Thank you very much for this. And the next talk will be by Professor Manas Panigrahi, and he will speak on management of brainstem tumors in children. This is an area which we all fear to touch as surgeons, because we know it could be devastating or it could be like anything. So this is a very difficult topic, and the surgery is really very worrisome for all the surgeons. So over to Professor Manas Panigrahi for speaking on tumors of the brainstem.
Yeah, good morning. Thank you, Dr. Suchanda. And,
slideshow. Enlarge your slide.
Yeah. Can you see it now? Or
we are seeing, but you can just go to the slideshow mode. We are seeing it. You just click the. Also, yeah, correct.
It's okay.
Yeah.
Okay. The pathology part was already spoken by Dr. Megha, so I thought I'll concentrate on speaking on the surgical approach for brainstem glioma. Dr. Majumdar spoke both on pathology and a little bit of surgery and on the pathology and the clinical features. I will just concentrate only on the surgery, because in 12 minutes I thought I can give some information only on surgery. As Dr. Suchanda was telling, that the burden of disease in India is quite high, but the detection rate and the places where the treatment options of the pediatric neurosurgery centers are very few. And brainstem tumors, of all the posterior fossa tumors, brainstem tumors are 18% of them. There are no gender predilection, but then they can be 5 to 10 years of age, but there is a second peak at 30 to 40 years. The tumors grow in a different way in brainstem. Normally, gliomas they grow along the glial fibers or all the association and fibers of the corpus callosum. But in the brainstem, because of the decushion of fibers, they do not grow along the brainstem. They restrict the growth. Like a medullary tumor cannot grow to the pons because of the decushion of the fibers, the corticospinal tract and the sensory tract also. So similarly, midbrain tumors tend to grow superiorly into the thalamus, but they do not grow into the pons. And pontine tumors, usually they do not infiltrate the midbrain and medulla. They confine within the pons, and the commonest tumor is DIPG. Say medullary tumors, they do not go to the pons, rather they become exophytic into the fourth ventricle, or they can go into the spinal cord and become a cervicomedullary tumor. So this is an example of a midbrain tumor which grows into the thalamus rather than into the pons. Now this is an example of a pontine tumor which remains confined into the pons only without infiltrating the midbrain or medulla. Now it can be a focal or diffuse, which has to be diagnosed to decide on the treatment. Now this is a medullary tumor which goes into the spinal cord or into the fourth ventricle, but then it does not cross the pons. You can see here the barrier between the pons and the medulla here. Now, the classification of brainstem glioma, the first one came in 1985, where Professor Epstein has classified into diffuse, focal, and cervicomedullary as intrinsic and exophytic tumors. But then over a period of time, this classification was, when Professor Epstein was given, was based on a CT scan only. But the latest classification, where Professor Charles gave in 2000, where they took the peculiarities of the CT and MRI and divided the tumors into 4 types. Type 1 was diffuse, type 2 is intrinsic or focal tumors, type 3 are exophytic tumors, and type 4 is cervicomedullary tumors. Barkos he classified depending on the region. He divided midbrain, pons, and medulla, and then he divided ventral tumors and dorsal tumors in each region. And the approaches was decided depending on the location, whether it is dorsal or ventral in the midbrain, pons, and the medulla. So I'll be discussing taking tumors in each region and then discussing the right approach for each tumor. Now, when you tell diffuse, that the definition is when more than 50% of the brainstem in axial scan is the tumor is more than 50%, it is considered as diffuse, but if it is less than 50%, it is taken as focal. As I told you, that the brainstem gliomas have two peaks. One is between less than 10 years, 5 to 10 years. The other peak is 30 to 40 years. Now, there is a distinct difference between brainstem gliomas in children and adults. As you can see in this slide here, which is published in Neurology India last year, the diffuse glioma, DIPG, is more common in children. Like 80% of the brainstem tumors are DIPGs, only 20% are focal tumors. In comparison to adults, DIPG constitute only 40 to 50%, whereas focal tumors are almost 50 to 55%. Now, the other classical difference is in DIPG in children, the median survival is only 1 year, 8 to 12 months, whereas in adults, the median survival is 4.7 to 7.3 years. So DIPG is bad in children, but it's very good in adults. Whereas focal tumors in children, the median survival is more than 5 years, whereas in adults, most of them are malignant tumors, and the survival is only 1 to 2 years. So it depends on the age how they behave in the survival. It's not that all DIPGs are bad. Now, this is a classical pontine glioma where the tumor occupies more than 50% of the axial brainstem. So this is taken as a diffuse tumor. Now, and there is no clear-cut margin of the tumor seen. And if you go back to papers which was published in 2009, it was a review. Then they considered that diffuse intrinsic pontine glioma is surgically inoperable, and they should be subjected to radiotherapy and chemotherapy, and there is no role of doing surgery or biopsy. But then, even in neuro-oncology in 2011, where consensus came that one does not need to do a biopsy in DIPG, except that there is a atypical findings. Then only atypical findings, because sometimes it can mimic demyelination or granulomas in developing countries. In that case, only one needs to do a biopsy, but it has to be done by an experienced surgeon. And so atypical tumors, only atypical imageable features only needs biopsy. Otherwise, it is not required. That was what was recommended in 2011. But Professor Mehta from All India Institute, from Paras Hospital, he published an article that all DIPGs do not behave the same way. He said among the DIPGs, there is a specific group of patients who can be resected. They are called expanding varieties or expanding. He introduced that in the classification should not depend only on the CT and MRI, but he included the clinical features. He said if the symptoms are more than 6 months and the patient or the child does not have much of deficit, and the size also may be more than 2 centimeters. Basically, if the duration is long and there is no deficit, then one has to consider surgery, as it is an expanding variety with the clear-cut margins, and these are the group of DIPG which needs surgery. But how do we diagnose this expanding variety? Is it only with the clinical, or because when they published, doing a dactylography was not very common. So this was improvised later with the publication, there are a lot of publication on DTI in brainstem gliomas. One of them, which came last year by Dr. Sridhar from Chennai, he said that when you do a DTI in tumors where the tracts are displaced, they are the expanding type, and they can be resected. So these are the group which Professor Mehta had was expanding type, which can be detected when one does a DTI. So it's essential that one does a DTI in a suspected DIPG, so that one can decide whether one can go for surgery or one can go for primary radiotherapy in DIPG suspected DIPG patients. So this is one case which we had operated when the initial MRI was suggestive of DIPG. I can see here that it is more than 50%. If I take the definition of more than 50%, it is a diffuse intrinsic type. But then when we did corticography of the means the DTI of the corticospinal tract, and can see here that the tracts are displaced to one side. A compact and displaced, and the tumor is classically is confined. It's an expanding type, and we did a surgery. We did through a Kawase approach. We did excision of the tumor. So this is an enlarged view where one can see that it's a focal. It's not a diffuse type, though it was initially predicted as diffuse, but after DTI, we classified that as an expanding type. So if you have a lesion in the pons, it depends on whether it's an anterior pons or posterior pons. If it's a posterior pons, one does a suboccipital craniectomy and televelar approach. But if it's an anterior pons, one can do an FTOZ, a subtemporal Kawase approach, or a pre-sigmoid approach. But what is important to know is, once you have exposed the tumor, what is the safe entry zone, or where one has to enter to cause minimal deficit. Now there are two areas one has to, which are described as safe. One, this is the fifth nerve. One is described as peritrigeminal incision. The other is the supratrigeminal incision. Ventral tumors has to be done in the supra. This is the fifth nerve, supra, and the lateral tumors has to be done in the peritrigeminal. Like this is the fifth nerve. One has to do anteriorly and medially. The incision has to be done anteriorly and medially to the root entry zone of the fifth nerve. So this again shows a cadaveric specimen where this is the fifth nerve. So if one has done a retrosigmoid approach, one has to enter the brainstem anterior and medial to the root entry zone of the fifth nerve. So this is a case which are done a brainstem glioma in the ventral pons. We operated through the peritrigeminal corridor with a retrosigmoid approach. Now this is a tumor of the dorsal pons, and this was operated through standard suboccipital craniectomy and televelar approach, what we do for the medulloblastoma. Now in these cases where the tumor is projecting into the floor of the pons, one is to identify the fifth nerve, the seventh nerve before making an incision. So the safest area of entry or the safe zone is to do through a suprafacial triangle or the infrafacial triangle. One knows that the facial colliculi has the facial nuclei here with the sixth nerve going around it. So one has to avoid that to prevent fifth and sixth palsy. One can go above that or suprafacial triangle, or one can go below that, the infrafacial, depending on the site of the tumor. Cranial nerve monitoring is very useful in tumors of the brainstem. Here, this is the palm, this is the brainstem, and here we are using the stimulation. Both we started with the surface and at that depth, and both for stimulation of the corticospinal tract as well as cranial nerve nuclei, as we do a sequential resection of the tumor. Tumors, let me tell about the midbrain tumors. Now, midbrain tumors, which are of the midbrain tumors, which arise from the ventral pons, they can project into the third ventricle. And if they project into the third ventricle, one can do either an endoscopic approach if they are less than 2 centimeters in size, or if they are larger than 2 centimeters, one is do a transcallosal approach, either through intropharyngeal or transchoroidal approach or transforaminal approach. Like this is an example of a midbrain tumor and with hydrocephalus. This is a 17-year-old with ocular symptoms. And this is another case again where one can see here that the third ventricle, the foramen magnum is quite wide. One can use endoscope to take a biopsy and do a third ventriculostomy for this patient. Now, this is another case of a 7-year-old with ataxia and weakness. The first stage we did a third ventriculostomy with a biopsy, and then second stage, this is the first stage. And though when we went to the endoscope, we already saw there is a spontaneous third ventriculostomy. We didn't have to do third ventriculostomy. And then we changed the direction of the scope. This is the interthalamic adhesion. And this is the tumor scene. This is the aqueduct. And we use the Fogarty to make an incision on the tumor and dilate the Fogarty so that it makes an avascular opening on the tumor. And if you, nowadays we use laser, so there is a avascular opening on the tumor, and then we take biopsy. While taking a biopsy, one is to remember that one should not pull the tissue, but it might bleed. Rotate the instrument there so that it detaches at that level. You can see here, once you hold the tissue, you rotate the tissue and then see that the tumor detaches. Do not pull, otherwise you will have inadvertent bleeding. And then the second stage, it was reported as pilocytic astrocytoma. Second stage, we did a posterior interhemispheric approach and excised the tumor. Now, this is another case who presented a 17-year-old boy who presented with gelastic epilepsy. There's a lesion in the midbrain. This is another case which had a cystic lesion. This is another tectal glioma which had a lesion on the tectal. And when there is a lesion in the tectum, the best place to enter is either infracollicular level or the supracollicular level. So this is a tumor where we entered on the infracollicular level. You can see here the fourth nerve, and just parallel to the fourth nerve, infracollicular level, we entered to excise the tumor. So the safe entry zone is either supracollicular or infracollicular in the tegmentum. Usually we do a combined approach, supra and infratentorial, and so this is the infracollicular incision. This is the fourth nerve seen there, and the tumor is excised till we see the normal tissue all around. This is another case where this is a pre and post-op scan, which is done as infratendicular supracerebral approach. A thin layer of tumor was left on the tectum to prevent any additional deficit. This is a pre and post-op scan showing almost total excision, maybe a little bit of enhancement here. This is the patient with gelastic epilepsy with total excision. Again, this is the tectal glioma, and this was pilocytic astrocytoma. And this is total excision. He came back after 3 years with a recurrence when we had to give irradiation. So these are the reasons how we operate if it's dorsally situated. But if you have a lesion in the ventral midbrain, the best approach is to do a FTOZ or a transsylvian approach. And the best entry point is lateral to the root entry or the root exit zone of the third lobe, not fourth. Or if the tumor is pointing on the subpial surface through the tumor directly on the crust. But one has to remember that the tracts are vertically oriented. So when one makes an incision on the crust, it has to be done vertically, not transversely, along the direction of the corticospinal tract. Now this is a tumor in the ventral midbrain and going into the thalamus, and where after excision we had used fluorescein to identify the tumor, and so you can see the tumor with it is yellow fluorescence is quite bright in this. And this was done with a transsylvian approach, the standard transsylvian. I'll go through the slide fast. And here, as I told you, one has to make an incision vertically on the crust. So the incision is vertically along the crust, along the direction of the corticospinal tract. And this is at the end of excision of the tumor. You can see the normal. And fluorescent dye is used, which I showed the picture earlier, to see that we have excised the tumor totally. So if you have medullary tumors, the best, if it's posteriorly situated, the best place to enter is the posterior median fissure or the posterior intermediate sulcus between the gracile and cuneatus fasciculus, or lateral to those two fascicles. These are the 3 areas which are safe entry zone in the medulla. And if it's the upper medulla, it is infrafissural triangle. So this is a cervicomedullary tumor. This is another case of a cervicomedullary tumor where it was done through the standard suboccipital craniectomy. And as the tumor was bulging, was seen subpially, that was the safest entry zone. And ultrasonic aspirator was used, and with intermittent stimulation. The tumor was excised, preserving the normal plane. And this is the post-op scan. A little bit of residual tumor is left inside the medulla here. What are the cases were done, we published, and what we found was that low-grade gliomas had a better survival, like 5-year survival, and the high-grade gliomas had 1-year survival. Complications, we had 10% of the patients had additional deficit following surgery, and we had a mortality of 3% of all the cases we had done. So take-home message, brainstem gliomas can be treated surgically, but one has to do proper investigation. 10 years ago, it was taken DIPG has to be given primary radiotherapy, but at present, one has to do a DTI, identify the expanding variety, especially in adults, and one can give a better prognosis as the survival is more than 5 years. And in children also, one should not be nihilistic. If the DIPG shows an expanding variety, one has to offer surgery instead of giving direct primary radiotherapy, as well as the tissue is helpful in in molecular diagnostic, as Dr. Megha told, that we still can have better results if we have a histological diagnosis. Thank you for your attention.
Thank you, Professor Manas, and it was really a very lucid talk and a lot of information. And for people who are like, very upcoming neurosurgeons and brainstem surgery is a nightmare. And I think this talk has done justice. I don't see any questions in the chat. Joy, I've been asking repeatedly everyone to send some questions, but then we will take up at the end. And because I think by the time they will start posting some questions on the chat. And so we will move on after this beautiful talk to the next speaker, and that will be on ependymoma by Dr. Shibu Pillai, who is a passionate pediatric neurosurgeon and working at Narayana Rudalaya, Bangalore. So over to you, Shibu.
Good afternoon. So I'll be talking about how to manage posterior fossa ependymomas, which can be quite troublesome. And these tumors are very commonly found in children, particularly in the posterior fossa. Is it on slideshow now, on your view?
Yes, yes. Yes, it's on slideshow.
Yeah, we can see. We can see.
Not move. Okay. Yeah. So the WHO 2016 classification sort of reorganized the ependymal tumors using their molecular profile. And this resulted in 9 subgroups of tumors. And out of these 9, we'll focus on these 2, that is ependymoma A and ependymoma B, which present in children in the posterior fossa. And if you look at the fact that both these groups have both classic and anaplastic histology grading, this will explain why we have often found tumors which with anaplasia seem to have a good prognosis, and things which should have been grade 2 and a better prognosis end up with a poorer outcome. These 2 groups have distinct morphology and location, in that the ependymoma group A present in infants and usually tend to be more laterally located and end up having a poorer outcome, whereas the ones with ependymoma B tend to present in older children and adults and generally tend to have a better outcome. This was studied in more detail in this paper, which included almost 680 type A tumors and 140 type B tumors. And what they found is, if you look at all the factors which influence outcome, the fact that a tumor has ependymoma group A profile leads to the worst possible outcome. And this is irrespective of the age. So previously we used to think that young children are going to have a worse outcome, but this is not completely true. If they have younger children with a type B tumor are also likely to have a good outcome. Tumors which are not completely resected again have poorer outcome. Males have a worse outcome, and giving radiotherapy improves outcome. So these are the things which come out from this study. If you look at management per se, when you have a patient in front of you, the 3 factors which come into play are, one is the extent of the tumor and how much you've been able to resect, the age of the patient, whether it's less than 18 months or more than 18 months. And third thing is whether there has been metastasis, particularly into the spinal system. So using these 3 things, we can decide how to manage patients. And we look at that using 3 cases. So firstly, we have this 4-year-old boy who came to us in 2016 with a 2-week history of headache and vomiting. The MRI showed this picture with a tumor which is extending into the right CP angle. We operated, and fortunately we were able to excise the entire tumor. The pathology turned out to be an anaplastic ependymoma. The post-op MRI showed that there was no residual. We did a spine MRI and CSF study which showed there were no metastasis. The child had a poor gag reflex and was started on RT feeds. After this, what would be the ideal way to manage this child? Should we give some kind of adjuvant treatment? What kind of treatment? And will the pathology, that is the fact that this was an anaplastic tumor, is it going to affect the child's prognosis? These are some of the questions that come to mind at the end of at this point. So one of the consensus statements which was published after the WHO 16 report stated that all children, irrespective of the extent of resection, should, as a standard of care, receive post-operative focal radiotherapy, which ranges from 54 to 59 gray. Only thing is, you can reduce the margins of the target volume to about 1 centimeter, and that will not change the outcome. The other important statement is that we need not look at whether it is grade 2 or grade 3 while deciding the management. We followed up this kid, and over the years, at 4 years later, after the child had received RT, we found child is doing well. The tumor has not recurred, and this shows that how you, in spite of being an anaplastic tumor, according to the old grading, this child has done very well. So at this point, the question is he cured, or should we continue to follow up? Should we keep doing MRIs, and if so, for how long? So this study looked at patients who underwent treatment for recurrent tumors after they developed signs and symptoms, and versus those who were operated just based on the MRI without any clinical signs. And the ones who were operated based on the clinical picture had a worse outcome compared to those who were operated just based on the fact that the MRI had shown recurrence. The other point is that if you look at the long-term outcome, the survival keeps dropping as the years pass, even beyond 10 years. So this means we need to keep following up these children over a very long period of time with serial MRIs. So the EANO consensus guideline summarizes all this by saying that every child suspected with ependymoma should be operated. We should attempt a gross total resection if it can be done safely. If after this we have to do an MRI scan, both of the brain to identify how much of the tumor we could take out, and if there is some residue, we should, if possible, try to remove that. At about 3 weeks, we should plan for a craniospinal MRI and also do a CSF study to try to identify any metastasis. Post-operatively, all of them should receive radiotherapy, and long-term follow-up is absolutely essential. So we'll move on to another child in whom we were not so lucky. So this young girl came to us with headache, vomiting, neck tilt, and ataxia. And this MRI showed this large tumor, which was again extending into the CP angle. Following surgery and a near total resection, where we had to leave a little bit of tumor on the brainstem, we found the pathology to be an anaplastic ependymoma. Again, there was fortunately no spinal metastasis. This child had to be on tracheostomy and PEG following the resection. This is a post-op MRI, and here you can see how there's a small bit of tumor left behind on the brainstem. So what should we do about this? Does it need anything additional compared to the previous child? So we didn't do anything more. We gave the child radiotherapy. The small residual disease was followed up, and at 6-year follow-up, we can only see that small residue in the roof of the fourth ventricle. So, like I said, we need to keep the child on follow-up, but if we find that it is growing, what do we do then? The consensus about this kind of a situation is that we need to, if possible, reoperate. But in this child, we know that it is attached to the brainstem, and we are likely to not be able to resect completely. In that situation, radiotherapy is one of the options that can be taken up. And when you're doing repeat radiotherapy, it is important, as proven in this study, that craniospinal irradiation should be added. That's because when you compare infratentorial ependymomas at recurrence, outcome is much better when you give craniospinal irradiation compared to those who have received only focal radiotherapy. We'll move on to recurrent ependymomas. So far, we have been able to control our tumors. But what if, like in this 5-year-old boy, we find that the tumor keeps coming back? So this boy came to us initially at 2 years after an surgery done outside, subsequently had 2 further surgeries, and now we have a tumor which has once again started growing from the upper midbrain, upper part of the midbrain, where a small residue was left behind. Child has already completed radiotherapy and chemotherapy. So now what can we do? What's the role of chemotherapy? So far in none of the patients have we tried chemotherapy, because that's really not very beneficial. But in this kind of a situation where repeat surgery is not something you're going to use, chemotherapy does have a role. So this study showed that if you give chemotherapy in such a child, you can, after about 7 weeks of vincristine along with etoposide and cyclophosphamide, you may find some tumors have now become resectable and they can undergo second surgery followed by re-radiation. In others, you find that they are unresectable and then you may only have repeat radiation. So when you find that they respond to chemotherapy, one of the options is that you can continue them on maintenance chemotherapy for a longer period, and this might give you some more time. If on the other hand, chemotherapy doesn't help, what kind of radiation can you offer? Because they've already gone through a significant amount of radiotherapy previously. In this situation, stereotactic radiosurgery or proton therapy might have a role. Unfortunately, there aren't too many randomized trials in this, and we have only anecdotal reports about the benefits of these treatments. Proton, although it had a lot of hype around it, there are now reports coming that brainstem toxicities might be too much. So what have we to look forward in the future? What we now know is that ependymoma A definitely have a worse outcome, and this can be identified by a simple immunohistochemistry looking at the H3K27ME3. So if we are able to differentiate them simply, then ependymoma A tumors may be benefited by early escalation of therapy, whereas ependymoma B tumors, which have good outcomes, may actually be benefited by de-escalation of therapy and avoiding radiotherapy and its consequent problems. So these are things which we need to study in future trials. So summarizing the overall management strategy, the most important thing is gross total resection. And irrespective of whether the pathology turns out to be grade 2 or 3, they need a similar management. All of them need radiation therapy, except those who are less than 1 year age, where chemo can be considered. If you end up with a subtotal resection, you should definitely try to re-resect if it is possible. Surveillance imaging must continue, and this is a long-term strategy which will continue for many years, even beyond 10 years, with regular MRIs. If there is recurrence during this follow-up, a craniospinal radiation, in addition to the focal radiotherapy, may be beneficial. However, we still don't have many strategies for late recurrences, despite all these advances. Further studies, including molecular subtyping and de-escalation or targeted therapy for different subgroups, may ultimately be the way to go forward. Thank you. Any questions? Yeah.
Sorry, you all are making it so clear that people are actually not having any questions. So, but somehow I have lost everyone can hear me?
Yes, we can hear you.
Yeah, but somehow I am not seeing anything. Anyway, so what we do is next presentation. Hello?
Okay. Dr. Shibu, I just posted a question.
Oh, okay. Where is that?
Grade 2 is
required.
Your summary slide said after surgery
So that
whether grade 2 or grade 3,
yeah,
or require do all.
so that's what I was saying about the current consensus is that irrespective of the grading of grade 2 or grade 3, you should give radiation therapy. The only question which remains to be answered is among ependymoma type B, group B, you may have a subset of patients who will do very well in spite of not giving them radiation therapy. But how to identify them is still not very clear, and that will need to await further trials. But yeah, if you identify them as group B, there are studies which show that you can avoid radiotherapy, and when they recur, if you give radiation therapy at that point, they will still have progression-free survival of up to 8 to 10 years. So in group B tumors, you can wait. You don't have to look at whether it is grade 2 or grade 3. It's the molecular profiling which is important.
So there was a question, I don't know, in the chat if you can see that whether some Dr. I has written that.
IP Cherian has asked whether giving focused ultrasound helps in chemotherapy. Dr. Sibu. As far as you know, for focused high focus ultrasound is not available in India. There are a few centers in US and Europe. So it is not there. Dr. Sibu, you know anywhere HIFO is there?
No.
Yeah, they're using only for fibroids in uterus. They're not yet started using in brain in India. Apollo Hyderabad has a HIFO, but they don't use it for brain.
So Paritosh has put up a question about grade 2 ependymoma with residual. Should we do resurgery or radiation? So like my second case, if there's a small residual which cannot be resected, for example, it's adherent to the brainstem and you would not like to risk more deficit by trying to reoperate, then radiation therapy directly would be the best option. If you can resect whatever remains, then you should reoperate.
Okay, then we end your talk here, and because officially we have 2 minutes for Ari, but then we'll give you the whole time. Don't worry, Ari. We go to the last talk for Dr. Ari Vezagan, and he will be talking on very important topic. I mean, not the histological types or anything, but factors influencing long-term outcome in pediatric posterior fossa tumors and integrated evaluation measures, need of the hours. We know that more and more children are surviving from these diseases, and so this is really the need of the hour. And we have Professor Ari here, Ari Vezagan from NIMHANS Neurosurgery, to tell us about that. Over to you, Ari. Ari, we are not seeing you yet. Hello? Hello?
Yeah, can you now?
We are not seeing you.
Yeah, can you hear me now?
We can hear you, yeah. But
you can see and my slides are shared, right?
Yeah, we can see you. We have to see your slides.
Yeah,
yeah, you have started a screen show.
So good afternoon. Thanks NSI and thanks Dr. Suchanda. So I'm the last man standing, and I'll talk on a topic which is slightly off bit, which is in comparison to other topics, but I think it's an integral part of overall management. So let me touch upon on these issues, which I think are important to be aware, both from the patient's perspective as well as from the clinician's perspective. So we covered all these types of common tumors in the posterior fossa in children, importance of surgery, role of radiochemotherapy, and what we've seen also over a period of last 2-3 decades, there is significant improvement in survival for a lot of long-term survivals growing into adulthood. As we saw, the 5-year survival in medulloblastoma is anywhere near 90%, and that in ependymoma is ranging between 30 to 70%, and with pilocytic to be even better. The question is survival, which is measured as overall survival and or progression-free survival, is that enough? In our mind, I think it should not be enough, and now there are more and more emphasis that is coming on the other components of life, which is just beyond survival, where we need to look at the quality of life, physical outcome, cognitive outcome, endocrine, and psychosocial features in these patients who are really long-term survivors after a very useful and very successful therapy. So what is finally important is the integration of this patient after therapy into society, which is the most important, and that's what one should strive in the overall care. This slide would probably summarize the whole topic discussion of my talk today. As you see, over a period of time, starting from early 1900s, 2010, till 1960s to 70s, major emphasis was on survival of the patient. If you look at the red line, the mortality touched anywhere to less than 5% by 1980s, and till 1970s, the talk was more on symptoms and survival. Whereas as the 5-year and 10-year survival increase over time, the emphasis is more on quality of life, aging, rest of family, as well as a community integration. And this is what is important now, especially in posterior fossa tumors in children. So what all can affect this outcome? One, the disease per se, because the disease itself can cause damage and it can progress, it can recur, and that can have an impact on the quality of life and cognition and physical balance. Second is the surgery and the techniques of surgery. Third is the treatment of radio chemotherapy, which can also have impact on that. So we will see what each factors can do and how we can minimize each one of them. So since we are surgeons, we should know what we can avoid by or giving less harm or no harm in what we do. First is we all know that to avoid motor imbalance and ataxia, we should avoid splitting vermis, which is avoided most of cases now. And the second is do more kilovelar approach and decompression of the tumor so that the damage to the vermis and to the paraverminous structures can be avoided. We all know about this syndrome, which is very common now. If you look at the incidence, it's about 11 to 30% of cerebellar mutism syndrome or posterior fossa syndrome. This happens because of not just damage to the bilateral dentate nucleus, but also due to damage to the fibers or the pathway, that is the dentato-rubro-thalamocortical pathway, which connects the cerebellum to the cortex. And bilateral damage can result in a syndrome, which can consist in different combination of ataxia, mutism, hypotonia, ability. So how we can avoid? One is avoid minimal or no retraction of the cerebellum, as well as prevent damage to the paraneal pathways and dentate nucleus. So why this is important? We see these patients more commonly, and we tell them that okay, patient has developed mutism in the immediate post-op period. It is, we all believe that it is known to improve and that is fine. But if you look at these children who have developed cerebellar mutism syndrome and compare them to others who also have for the surgery, we can see that damage is not short term for a week or a month. Even in this study, as you see, they surgery, and they notice that those who have developed cerebellar mutism syndrome had broad spectrum damages both in verbal comprehension, language, spelling, as well as in general intellectual ability when compared to those children of posterior fossa tumors who did not have this. And not just enough, if you follow them for a longer period, you see even up to a period of 3 to 5 years, there is a decline in across the spectrum of intellectual ability, attention, processing speed, working memory in these children who develop cerebellar mutism syndrome post-op, thereby bringing home the point that we should try our level best in all our surgical maneuver to avoid cerebellar mutism syndrome in those children. That's point one. Point two, what about the white matter? These two papers also show that those children who have a significant white matter damage post-op as well as post-radiotherapy are known to have significant cognitive disturbances as well as memory disturbances. Thereby, even in a surgical maneuver as well as in treatment of radiotherapy, avoidance or minimization of white matter damage, dissection only restricted to tumor and not just because it is cerebral, we can cerebellum should be avoided as a matter of fact from our side. The radiotherapy, as the patient undergoes surgery followed by radiotherapy, if you look at the effects of radiotherapy over long term, this paper showed that if you evaluate this patient's brain at the follow-up after long term, there are areas of decreased cerebral perfusion as well as diffusion coefficient, decreased ADC values, indicating that the damage due to radiation is just a short term. It can affect the perfusion as well as the diffusion of this brain, and which can be the precursor or which can be the reason for the cognitive defects that these patients develop later. Another important part or another important direction which most of us forget or which most of us do not concentrate on, the development of endocrinopathies in these children. These are growing children. They have a varying endocrine functions during the period of various stages of growth, and both disease as well as the treatment can affect this. As you see, who are at risk, the RT, both focused RT as well as craniosspinal irradiation can cause deficits, and those who treated with high dose of alkylating agents like cyclophosphamide and busulfan can have. And also, one paper noted even the tumor-induced damage can have effects on endocrine the function, and it can cause endocrine problems. So we need to be aware of this. What is the extent of published in 2008 by Lawton et al., who studied the effect of endocrinopathies in these children over a period of time. If you see, the most common GH deficiency can occur as early as 12 to 24 months from the time of treatment, followed by TSH deficiency. And if you look at the incidence, up to 90% of the children who underwent surgery and radiotherapy can develop GH deficiency. So that, and up to 50 to 60% of them can have hypothyroidism. So how they can present? They can have poor growth, thyroid dysfunction, pubertal delay, precocious puberty, osteopenia. Many of these can be considered as part of radiotherapy itself, but then an important emphasis need to be given to assess these children so that they can be integrated and they can have a normal growth. And this dose hormonal deficiency can also be dose dependent. People who receive less than 30 gray can have predominantly GH deficiency, and those who receive 30 to 50 gray, the frequency of GH deficiency can go up to 100%, and TSH, ACTH can vary between 30 to 5%. So that brings home the point that the children who undergo treatment just not assessed over survival, but they have to be looked for endocrine dysfunction, hypofunction, and if they require supplement, they need to be given that so that they can have a overall outcome and integrated growth. There's a lot of talk about assessment of cognitive dysfunction in these children in long term. I'm not going to go in detail. Suffice it to say that these children on long term have been known to have progressive decline in intellectual functioning, selective attention impairment, long term neuromotor deficits, and there's a lower rate of high school graduation and employment related when you compare to the overall population. As we want them to become adults, we also want them to be grown up functioning adults and not just being there. If you look at, there are a lot of studies which have been done which assess and shown that across various spectrum at executive function as well as working memory, these children are faring less and would require an intervention so that they can do better. I will skip this slide. And it's also important that to know that this does not occur only with malignant tumor like melanoma. It is also known that even children with pilocytic astrocytoma who are expected to have a long outcome, irrespective of the type of therapy that they receive, whether it is only surgery or radio chemotherapy, what has been found that these children on a long-term follow-up have invalidating cognitive impairments, and those who have got initial severe deficits can continue to progress further because of a growing into deficit phenomenon, and therefore they need to be evaluated not just with MRI but also for their quality of life and cognitive functions and long term at every follow-up. And there are few studies on identifying the factors which can affect quality of life. This paper from Sick Kids showed that, this is from Canada, Sick Kids, which they also showed that children with income who did better was those who are high income. And when there is hydrocephalus, which can, even if they've treated, it can affect quality of life in long term. So what about Indian data? There are sparsely any Indian data regarding this. There are a few papers which have come from a TMH group that time, where the study has been done only on where they compared
Harry, we are missing your connection. I think we have lost connection with Dr. Harry.
Yeah, we cannot hear now. Both picture and sound is gone.
Your sound is gone, yeah. No slide is coming, Harry.
Just a minute.
Just come again. Yes.
Yeah, just a minute. I hope. Am I on track?
Yes, yes, you are on the.
Yeah, yes.
Sorry. There are not much data from India except for this review article from TMH group again. And these points need to be considered in overall evaluation of these patients. And so we did a study from India, which about a year ago, this under considered for publication. We compared 50 children prospectively who have undergone treatment for malignant posterior brain tumors after their adjuvant therapy and looked at their clinical status, what is the quality of life, cognition, and neuropsychological evaluation. We wanted to see what is, my hypothesis was they are doing, my initial pre-hypothesis was they are not doing well. We need to see how they do. And we noted that before the treatment, 60% of them were into schooling, and then after treatment, again 61%. Though the numbers look same, that as the children grew, the point we found was in our cohort or in our scenario, it takes almost 1 year loss for the child to get back to school, probably because of the surgical morbidity, period of recuperation, then during treatment. But nevertheless, we found many of them, if not severely disabled, get back to school after a lull period of 1 year. And if you look at the quality of life of all these children, this was prospectively analyzed. We were happy and surprised that most of them had very good average quality of life scores across various domains that have been tested. So that showed that they were having a reasonable quality of life after therapy. However, if you look at the neuropsychology, we found that almost 60% of them fell into a category of below average IQ, when despite they had a reasonable or above average quality of life scales. The two factors that were affecting or influencing was that we found that children who had mothers maternal education, which was affecting children who had mothers who did not have a high school education, we found that most of them were into below average IQ, and children who belong to low socioeconomic status also had more incidence of low IQ. And we noticed that the quality of life scores did not really compare or correlate with the IQ levels. Thereby, children can have good quality of life scores, but still have significant cognitive function if you assess them with relevant neuropsychological parameters. And what we found that children with or higher maternal education, high socioeconomic status, and younger children had a better quality of life and cognitive outcomes. And what did not affect in our cohort, that the duration post-adjuvant therapy or tumor location or V-patient chemotherapy, V-patient did not affect the quality of life in our cohort. Coming back to summarize, we need to realize that the survivors of medulloblastoma, or for that matter, all posterior fossa, will have persistent, severe cognitive deficits and quality of life issues, and they need to be aware, made aware, and be addressed in the long-term outcome. To summarize, the point which we need to understand is that outcome is more than survival, and quality of life matters. So when we look beyond having a patient who's not free of disease or an MRI which is clear, we need to look at its patient's endocrine function, physical quality of life, and neuropsychological needs, and that those need to be addressed. And follow up. Thank you.
Thank you, Dr. Rari. Thank you. It was a very good talk. And is there any question? I don't see in the chat as of now, but some people
I have a comment for Ari. Ari, I think you have highlighted a very important topic. And I think the most important thing is that the neurosurgeons have very little time to see these patients in the long term. And most of these patients are monitored by radiation oncologist or medical oncologist. So it is important, like what we do at Tata Memorial, that the neurosurgeons have to take part in their social gatherings and see how these patients do perform, and will be surprised to see that many of these patients with posterior fossa tumor who are long-term survivors do really well in terms of their artistic values or educational values if they are, if they're followed up in the long term in a good rehab center. So what Hari has mentioned is a very important topic. We neurosurgeons do not usually follow these patients long enough to see all this what Hari has mentioned.
My comment on that is, I'm not clear why we should, because the patient, the first contact starts always with neurosurgeon and we operate them. And then, of course, radiation oncologists treat and follow. Like I showed, if you look at it, most of the side effects or most of the effects come because of radiation chemotherapy. So therefore, but then I think we can never absolve our responsibility from following up these patients. And we should also be aware that if suppose there are children who are being followed up only by neurosurgeon or who are seen more commonly by neurosurgeons, if we are not aware that we need to evaluate or assess these children for this, they are at a loss. And I think it has to be considered as an overall or a collective responsibility that all of us be aware and evaluate these children, not just on MRI. And I think strongly I believe that it's neurosurgeon's job is not just to see MRI and at the end no residual lesion and then we can be happy about it. We should also see a child who has grown into adulthood and gone back to a job and have integrated into society.
Yeah, any other questions from any speakers or the delegates?
There are some questions in the chat.
Yeah, there are questions in the chat.
On CSF leak and posterior fossa syndrome for Dr. Mazumdar.
I'm not able to get. Anyway.
Question from Dr. Vikram and.
Yeah, I think Dr. Mazumdar addressed the CSF leak answer, isn't it? Hello.
Hello. Yeah.
Yeah, I think Dr. Majumdar has addressed the answer. So,
Suchanda, one question to all the panel.
yes.
So how many of you all pay attention to making your dural closure perfect, or is it just okay to just put a patch, leave it there, loose? So what is your philosophy?
As for me, I take...
Dr. Mazumdar, you are muted. Dr. Mazumdar, you are muted.
So for me, as possible, the dural closure has to be perfect. Tumor has to be removed, brain has to be lax, and dural closure has to be perfect.
Yeah, I agree with that.
Yes, same here. We use autologous. If by chance you don't get an autologous in a very small, sometimes we have used once or twice, we have used Duragen and it was okay so far. I don't know, but people do have complications as well.
But we use a crescent dural opening, and 98% time we can do a primary dural closure without any graft, no autologous graft or no Duragen, and the incidence of CSF leak and pseudomeningocele has drastically come down.
So actually, someone has asked about your expert.
We don't use it.
Yes, someone has asked about experience and need for posterior fossa. Hello.
Yeah.
Hello. Hello.
Hello. We have lost you, Manas sir.
Hello.
Your audio is not.
You can hear me now or no?
Yeah, yes.
Yes, you can hear.
Audio is not.
Yeah, now you
can hear. Yeah. No, what I was telling was that doing a crescent shape dural opening, preserving the marginal sinus and occipital sinus, we've been able to do a primary dural closure most of the time, and we never had to use an autologous graft also. And by using that, our incidence of CSF leak and pseudomeningocele has significantly come down.
Yeah, Mr. Prashant has asked if anyone does an LP shunt for all these cases. Or
Not at all. Not at all. Not required.
I don't think so. We do, if required, we do a VP shunt, not an LP shunt.
Yeah, so we have to do a CT scan or MRI first, rule out hydrocephalus, and then take it forward. If it is ventricles are dilated out of proportion, do a VP shunt, or you do a TP shunt. I think LP shunt, lumbar drain carries a risk of infection if it is more than 2 to 3 days. So I'm not for lumbar at all. Either I have to do serial lumbar punctures rather than do a lumbar drain.
Yeah, but the question is that with the newer and newer, Megha, this is for you, newer and newer, your all this molecular genetics and all coming and making us really to remember so many things is becoming very painful. I don't know how many sub-classifications you all are going to bring out and whether the management is going to do your thoughts on that. And after that, we'll take a closing statement and stop it, right? Because we are anyway over time.
Yeah, but I mean, that's true. Yeah, I mean, for pathologists also remembering all those molecular genetics at one go really becomes very tough. If you see the number of techniques, they are just never ending. But from the rest of the talks, it is very well understandable that molecular subgrouping does play a major role in deciding the patient management. So there is no way going back. I think we just have to put in our efforts, get as many techniques as we can, and give that molecular diagnosis which is required, because it's only a way ahead from here. We have to have the molecular diagnosis. It's tough, I understand, but then we have to make our way through it.
So I think it's time to stop. But before that, I have a question for all of us, that how many of us are routinely using intraoperative neuromonitoring for mapping as well as monitoring for this posterior fossa?
I don't use it most of the time because of the constraints, number one. And second thing is, most of the time I don't feel like it is required in each and every case.
And anyone else? Any thoughts, Manas sir?
I think for brainstem we use, I'm sure Dr. Sibu also uses, but I had a question to both Dr. Sibu and Dr. Majumdar. How often you do post-op MRIs when you follow up your patients in grade 2?
Post MRI we do.
And how many years?
How many years?
Yes.
How many
how
years?
Often and how many years?
So the first post-op MRI is repeated if the patient is stable within 20 to 48 hours. Otherwise, do it at 2 to 3 weeks. So that's the time when the radiation, we in the tune with radiation oncologists, it is an MRI to decide further course of therapy. And then it is every 3 months for the first 1 year, and then every 6 months, and then every year. So 5 years do this exercise till the patient is, we know whether it is relapsing or under cure or whether we need to do anything else.
So this is stable. You do every 6 months.
Yes.
Yeah, in the initial 2 years, definitely every 3 to 6 months.
Yeah.
Beyond that, depending on what we are seeing and how the patient is responding, tumor is responding, we can increase the frequency. After about 5 years, I increase it even further, like maybe once in 2 years. But I still keep watching them with MRIs, and I insist that they come back and get evaluated. Otherwise, they'll be completely lost.
Yes.
Yeah, but that is the point I have doubt. So as the time goes by, the chances of recurrence actually increases.
Yeah,
so
you should keep
that
doing.
Concept means as the time goes by, it should be doing more frequently rather than more spacing it apart. The initial part should be frequent, in between it should be less, and then later it should be more frequent. That is what means. What is right?
So
because the recurrence again will come after 5 years.
The reason I sort of evolved into this kind of practice is with this so far I haven't yet gotten into trouble, but you never know. At some point,
maybe if we talk of logic, after 5 years they will recur. So that time I need more often, is it not?
But Manas, our experience shows that I think most of them may be agreeing with it, that in the long term, it is the experience. This thing relapse rate is not that high to get MR for each and every patient. So it will be a huge resource problem if we do MRIs repeatedly, as you say, in the long term. So most of the time they become static or they go into remission. And if there is no other reason, I don't think you should need to do an MRI because it would add on the burden on the patient as well as the system.
But what is the survival of the medulloblastoma?
Survival is fantastic. That's why I told that these patients, if you see the survivors, I am amazed to see how they can sing, they can dance, they can attend school. All these things we have seen. That's why I said we have to get integrated into the social aspect also.
So I think yes. Before that, I see Dr. Dev Pujari.
हाँ आया था सर नहीं सर
Can you listen? I think you are
हाँ सर पीछे बैठा था
nice time. I think we all
yes
Sir, I think it's online, but I can see
Online, he's online, but I cannot hear his sound.
we cannot
Voice.
hear him. So anyway, this webinar was the concept evolved from Dr. Dev Pujari sir only. So I thought I would thank him here, but I think he's not hearing. So I thank all the speakers to be.
सर को ये लोग बुला रहे सर सुन नहीं रहे
Sir अभी थे. I saw sir.
So anyway, thank you all, and I think we'll meet again in some forum like this, and we'll continue with this forum. Thanks each and everyone for being a part of this.
Sir, on the webinar, your video is showing, no? They were asking for you. They're asking, they wanted a word from you. Closing comments में. Switch off. अभी बंद कर रहे हैं. They are closing down. Okay.
Sir, we are wanting to hear from you something. No, he's probably not there.
From whom? Let it be from sir. From Dev Pujari sir. नहीं मैं सर के नाम से नहीं हूँ. सर अपने टैबलेट से देख रहे हैं. Sir, they are asking for you again. They said we are waiting for this thing word. आपका वीडियो दिख रहा है इस पे स्क्रीन पे तभी.
Anyway. Okay, then we'll sign off, all of us. I don't think so, Mr. Navneet.
Thank you. That was a good discussion.
Thanks,
Thank you.
Sujanda.